Thank you for allowing me to present this tips and tricks regarding T-branch. So good preoperative evaluation is a must for those patients as they have comorbidities actually. And you need to stage the operation to reduce the possibility of spinal ischemia and paraplegia. And blood supply to the spinal cord is from longitudinal arteries and segmental arteries. And here is a diagram showing the blood supply of the spinal cord. So CSF lumbar drain should be, or we prefer to put it to reduce the spinal ischemia. This was described by lumbar spinal drains for thoracoabdominal aortic surgery in 2020. And in this paper, the lumbar drain has been shown to reduce risk of spinal cord ischemia. Monitoring CSF pressure and maintaining it below 10 millimeter mercury to preserve spinal cord perfusion pressure. Revascularization of the subclavian artery when an endograft occludes its origin is another way to reduce spinal ischemia. CSF drainage should continue for at least 48 hours post-operatively and maybe up to 5 days. In the Journal of Vascular Surgery in 2020, the role of hysterical and procedural staging was described. And in this study, the data were retrieved from multi-center registry. A total of 240 patients had received procedural staging. They concluded that staging procedures were associated with reduced permanent spinal cord ischemia rates. Therefore, staging has been recommended. In this case that I will present, a male 73-year with comorbidities and has thoracoabdominal aneurysm. So we started with the zenith T-branch, and the plan was to put a T-VAR first, then we do the T-branch in a second stage. And here is the description of the T-branch design, which is the only available stent of shelving, and this is the sizing and preparation for the surgery. The image review, and we usually mark the SMA in the center of the grid, and you know all these steps, so I will just pass through it very quickly. And you have to know that all branches will be covered in this sheet, will be eligible to cannulate. So this selects the size of the universal distal body and step 9. So in this case, we will start with the CT angio, and we'll pass it. Here is a 3D reconstruction image. So we started with the T-branch, with the T-VAR first procedure. We're opening it. The deployment of the T-branch endograft is usually loaded, the endograft is usually loaded slightly twisted in its device. So all the markers should be anterior in position when you open it. And do lateral projection to ensure that the markers are in position. And usually you deploy the first stent first, then twist or clockwise or untwist or unclockwise the whole device to make sure that all the celiac and SMA are anterior. Then release the reducing ties. It's actually very hard to describe a T-branch case in 5 minutes. I'm not as quick as Dr. 𝗔𝘆 actually. So all the markers should be anterior, the 3 markers above the branches and below the branches. You all know them, these markers. And the SMA, and we start with the 3 markers. Here and there should be anterior. Then you start deploy, and then you start cannulate. The contralateral limb. A cannulation, big sheath with 20 French through the axillary artery, another support sheath through it to the first one. Then use navigation catheter to cannulate. The use of a steerable sheath facilitates this step. Secure your position in the visceral branches in the sheath case you need, in case if you need further relining stents or angioplasty. And this is the final procedure. CT scan follow-up. Thank you.